Hello, I'm Dr. Dan Duvall, Medical Officer with the Hospital and Ambulatory Policy Group at the Centers for Medicare and Medicaid Services in Baltimore, Maryland. I'd like to welcome you to this program titled A Roadmap for Small Clinical Practices. Joining me today are Dr. Joe Nichols. Dr. Nichols works on behalf of CMS as a contractor with Noblus, the project management office contractor responsible for implementing ICD-10. He is also the principal of Health Data Consulting and a board-certified orthopedic surgeon by training. He's currently involved full-time in healthcare information technology.
Thanks, Dan.
Gail Emmenizer is the practice administrator with Digestive Health Associates of Northern Michigan and is the committee chair for PACOM, the Professional Association of Healthcare Office Management Chapter Support.
Thank you.
And thirdly, Carla Bartlett is a registered nurse and director of continuous quality improvement at Fairfax Medical Facilities Incorporated, a federally qualified health center in Fairfax, Oklahoma.
Thank you.
Welcome to all of you.
Thanks.
The goals of this program are to identify the internal staff, functions, and processors within small independent clinical practices that will be most directly affected by the conversion to ICD-10, to explain how to plan and implement training, software, and procedural changes associated with conversion to ICD-10 within a small clinical practice, and to discuss when and how to initiate testing of ICD-10 systems, both internally and externally, to ensure a smooth transition by the deadline. ICD-10 is an enhanced or mature version of ICD-9 that more accurately reflects current medical practice. This allows reimbursement to better reflect the intensity of patient needs. Joe, for our audience, could you go over a little bit of a summary of ICD-10 to make sure everyone's up to speed?
Sure. So if we think about ICD-10 as the what, why, who, and when, from a what standpoint, it's really an international standard of the definition of health services that is mandated in the U.S. For all healthcare entities that are covered under the HIPAA legislation. In the U.S., it includes both diagnostic codes, which we call ICD-10 CM, as well as inpatient procedure codes, ICD-10 PCS. So why are we going to this? Well, currently, ICD-9 is 30 years old. It's a little outdated. We're not compatible with this definition that other countries use because they're on the ICD-10 standard by and large. We're one of the few countries that isn't. ICD-10 supports much better the medical concepts that are really important in terms of understanding the nature of health conditions. It provides better ability for us to understand risk and severity and complexity. All HIPAA-covered entities are required to use ICD-10. The compliance date is set 10/1/14, meaning as of that date, all claims with dates of service for professional claims on or before October 1st, 2014, and all inpatient claims with dates of discharge on or after October 1st, 2014, should be compliant with ICD-10 if you are a HIPAA-covered entity.
Thanks, Joe. Providers and others affected by ICD-10 have many questions. A good place to start getting answers is the CMS website. Resources that are tailored to practice size and setting, as well as specific questions and concerns, are available on that website. The companion video lecture for this program, ICD-10 Small Practice Guide to a Smooth Transition, is another good resource. Additionally, trade and medical associations may offer materials, training, and guidance. Converting to ICD-10 is doable. It's not optional, but it is doable. Any covered entity, as defined by the Health Insurance Portability and Accountability Act of 1996, will be affected. So if you deliver healthcare services in the United States or U.S. territories, this affects you. Many providers assume that the Centers for Medicare and Medicaid Services or their hospital administration or even their vendors will provide explicit instructions for the process of converting to ICD-10. But the responsibility lies with providers to comply with the deadlines for converting to ICD-10. However, there are many resources to help you get there. With just a little planning, you can move forward in a way that makes the most sense for your practice. The timetable for ICD-10, as just mentioned, has a few points on it, like the endpoint for conversion, but we don't provide details from CMS. Gail, can we start with you?
Sure. There's really not a rigid timetable for converting, but it's never too early to get started. There are certain things that you can begin doing right now. Some of it will depend on the size of the practice that you're in. It'll be easier, I think, for smaller practices than some of the larger or mid-sized practices. The fewer people involved, obviously, the less complex it is to get things done. Anybody else want to?
I do think that the size of the practice matters. The larger practices, I think, will have a harder time than the smaller practices were. They've got more to take into consideration there, cost and things like that. Timing's going to be an issue.
Right. I agree. And also the type of practice or the specialty that you're involved in, that's going to play into things as well. Some specialties or some types of practices are going to have fewer codes to worry about, and others are going to have a lot of codes to worry about. So all of those things are going to play into the process. There's other things to think about as well as far as the timing, billing, and that kind of thing. Do you want to talk about that a little bit?
Well, I think one of the things that I hear from folks is, yeah, it might be simpler because we're not big, but we also have less resources, right? So a lot of folks are saying, well, we just don't have the resources for training, we don't have project management. So hopefully, as we start looking at the smaller practices, they do have a lot less they need to do, but they also need to start thinking about how they're going to use the resources they had in a wise and appropriate way.
That's very true.
What about the type of billing practices that the practice has? Does that matter?
Well, I think it matters a lot because obviously if you're doing all the coding inside your own office, you've got to look at, will my super bill still work? If you're outsourcing your coding, is your outsourced coding entity up to ICD-10? Will they be able to take on ICD-10? So you really have to look at how what you do in your practice translates to how you bill, whether it's directly through your own office or through some third-party entity.
Right, I agree.
Well, given all of these variables that affect timing, when should people actually start? Carla, do you have any thoughts on that?
Now, yesterday. No, it's not too soon to start. I think they need to be looking at things right now.
Yeah, when I was talking to one group, we showed them the kind of standard timeline, and everyone looked at it and goes, wait a minute, the timeline's already down the road here. What do we do now? And I think we have to realize that it is very late to get started, and you need to start thinking about there are some things that you're going to now have to do in parallel at the same time. So not everything is linear. There may be some things that you could do at the same time moving forward to compress that a little bit so you can get the basic things. The other thing is prioritization. Some of the things that you'd like to do, you may not have enough time to do them. They may be able to push off a little bit further down the road. Maybe they're not so critical day one. So I think there's a lot of thinking about how you're going to adjust that timeline, given that it's very short at this point.
Right, I agree.
Is there anything in particular that providers should start with first, things that have longer time frames associated with the changes?
I think you need to look at, well, depending on your EHR system, if you have an EHR system, I think that's going to be a big issue. Does it accommodate the ICD-10? Our practice, we have a software that works with our EHR system, so, and then the testing and things to that. You've got to look at outside entities too. Are they complying with it? I worry about that. You know, if we transfer something with a certain code, is it going to connect with them like it should? I mean, are they doing the same thing? So,
well, and that's such a great point because if you have dependencies on someone else that are critical to your timeline, you may need to reach out quite a bit earlier to those folks because you may think they're ready, but they're really not. So making sure you understand all those dependencies and where they come in the timeline is important.
That's true.
So it sounds like then that systems and software and external interactions are the things that people should look at first. That's the most important thing to start with.
Right. Well, also the internal processes within your practice. I think it's never too early to start on some of that as well. Making sure that the physicians are documenting or the providers are documenting to the level that they need to already. Most of them probably already are, but it's never too soon to start looking at that and seeing, are we really where we need to be? Can we transfer this code and so on? And just I think in my case, I like to talk to my staff ahead of time and just say, you know, these are the things that are coming. And just saying the words every staff meeting every month for months on end, I think is very helpful because it gets in their minds that we're making another transition and they're thinking about it. And I think there's never too much you can do to keep people, you know, looking forward and keeping those kinds of things at least in their mind, if not top of mind.
It sounds like there's a number of points that people will have to think about as they're constructing this timeline. Examples of timelines for small practices are provided online by CMS on our website because this is a complex issue, and sometimes having a series of lists that you can look at can be helpful for providers, especially since this is not something you've gone through before. So a lot of the functions of the practice you've mentioned are affected by the conversion to ICD-10. Could you talk a little bit more about some of the specific functions that must be addressed for the conversion? Gail, anything that you haven't mentioned yet?
Sure. Well, I think really every aspect of the office is going to be affected in some way or another. But there are certain things that are obviously more important in the beginning to be working on. But we're going to need to think about our systems, as we've already talked about, the claims and your electronic health record, or if you're still using super bills, you know, how you're going to transition those. Assignment of codes, who's going to be doing that. Are they looking at, are they trying to convert now, looking at codes from ICD-9 and trying to see what they, you know, find them in the new ICD-10 books, those kinds of things. And so I think it's just general office procedure. Everything within the office is going to have some impact, some more so than others.
Right, and I think one of the things that's really important is that a lot of people forget is sometimes you forget the moving parts of your practice,
Very
right?
much, yeah.
So you think it's this, and then you actually go through the workflow of everything that you do, and you find, oh, here's an area where that might be impacted. So that exercise of walking through kind of the life cycle of the work that goes on in your practice is very helpful in kind of shining a light on where are some of those areas that you're going to have to look at.
So one of the key things it sounds like you mentioned were asking a couple of questions like, can you assign a code? And I would assume that going along with that is the question of, can you save that code? I mean, do you have ways in your systems of keeping track of it once you've assigned it?
Right, and I think the other thing is, can you assign the right code? Right? Because we're in a different environment. So.
Well,
I think it's going to require some auditing, testing. I mean, certainly we're looking at how the provider codes it with ICD-9, comparing it to how it would code with ICD-10, and making sure the documentation is there. The provider's going to have to learn some more documentation, I think. But yeah.
It's a great exercise to do, though.
Right.
Carla, your comment about auditing and testing raises some good points. If you're doing that, then I would assume you have to have some sort of training first. Could you talk a little bit more about the kinds of training that you think a practice would need to implement ICD-10?
I do know that there's some training offered out there for ICD-10. I think you need to stop and look at who all is involved, who in your practice, you know, this is going to affect. But there are some options out there for training, and I think you definitely need training.
Yeah, what I've found is that for the office, it's different training for different people.
It is.
Right. So there's the coder training. The office people really don't care about that.
Sure.
You know, they're looking more at what are the business implications. And the physicians really are not interested in coding, right?
Correct.
They just want to get this job taken care of in the most efficient way. So really for the physician, it's really helping the physician understand, yeah, we're documenting all these things, but what sort of things do I need to document that's going to make life easier for the person who's going to be coding it? What are the key concepts that I need to make sure get captured, which hopefully I'm already doing today. It shouldn't be anything new.
Right. I know what the other thing that I've found is from the coding perspective, just some reassurance and you know, giving them the tools that they need, and as far as having the new ICD-10 book available to them so that they can start practicing and looking and you know, checking out the codes that they currently use, those sorts of things, and seeing what the cross paths are, and then probably taking some or watching some video courses or training videos, that type of thing, or in person. I guess it doesn't really matter. But it's a lot of reassurance, I think, that it's really not going to be as bad as what everybody thinks it is.
It's such a great point. The big unknown is the scary part of it. It's really, once you get in, you say, oh, this is pretty doable.
Right, right.
Gail, you mentioned the book as the key tool of the coder, which absolutely it is. But in today's world, there are a number of software tools out there as well that can help. Do you have any tips or pearls that might be helpful for people as they're looking at some of these existing and potential software tools?
Well, I guess I would check resources first, because there's whenever there's a transition like this, there are products that are put out there that some are better than others, and so I would definitely ask for some references and that kind of thing. But yeah, there are definitely a lot of different programs that are available to help with the process. I'm not real familiar with a lot of them, but I do know that there are things available through a lot of the medical society type, or the specialty societies and coding societies, that type of thing, that will probably be a little bit more, well, I don't want to say more reputable, but I think I would feel more trust going through those avenues than some other avenues that are available out there.
I also think your primary care association is a good resource for training. For us, it has been. They've helped us quite a bit with things. So.
That's an excellent point. And the different specialty associations and the different primary care associations, I would think, have slightly different slants, because things are going to be a little bit different depending upon your specialty. Joe, could you talk about that from a physician's perspective?
Yeah, so the specialties are going to be very different because ICD-10, the way it's being implemented, is very different across the different specialties. So in areas that take care of musculoskeletal care, orthopedics, a lot of the primary care in the musculoskeletal area, there's been a very big expansion of codes. And in other areas, in other clinical areas, headaches or even behavioral health disorders, there's been fairly little change. And in some areas, there's actually substantially less codes. Hypertension, those areas, there's less codes. So there's a great deal of variability in those different areas.
But for most specialties, would it be fair to say that they're still dealing with that small set that they were used to dealing with?
Exactly. If we look at all the codes, and I've done some analysis of codes that have been used historically in 9, and what we found is that 5% of the codes accounted for 70% of the volume. It's a very small set of codes that we use today. Now, we will be using a few more in ICD-10, but still, we're going to be using a very small set of the codes. And it's really understanding those codes that you use. Even in musculoskeletal care, we tend to be somewhat specialized, and a lot of the codes we might never use in our particular practice. So it's really understanding that area. Yeah.
Good. Now, the flip side of that, from the coder's perspective, is the documentation. The documentation, the coding go together. Are there any tips that you have or any thoughts that you have for how practices should approach this whole question of documentation and coding?
Well, it's interesting you bring that up. I gave a talk just recently to a large group, and there was this whole concept of how do we get clinicians engaged in documentation, because currently documentation is viewed as a new burden imposed by ICD-10. But really, if you start uncovering that a little bit, most of the things that require documentation in ICD-10 really are the same things that you do today, just for good patient care. So the real focus on going through documentation is really focused not about this administrative burden that you need to do for ICD-10. It's really about these are key things that need to be documented for good patient care, and if you document those, then the coder will have more than enough information they need to get to the proper code.
Right, I agree. I've also found, in talking with some of my colleagues, that we find when reviewing our own medical records that everything is really already there, and in most cases in surgical notes, hospital notes, those kind of things. And the one area that sometimes might be a little lacking is more in the office notes, and it's really not a big jump from where they need to go. And I think they just need to, focus a little bit better on office notes. And in most cases, everything else is really pretty well documented in my experience so far.
Right. Has that been your experience as well, Carla?
Well, that was part of like what we're doing with the auditing, and we would have the provider, checking their documentation, seeing if they've coded it for the ICD-10 coding. And that's what we were looking at to see if they were meeting the documentation requirements to get those codes. Everything's electronic at our office now and has been for not real long, so this is all new to, still learning experience for us. But yeah, that's one of the big things with the documentation, and that's what we're auditing to make sure that they can document to get the ICD-10 code. And
are you finding, like Gail, that pretty much the documentation is there?
Mm-hmm. And your EHR system, most of them, it's all just a checkbox thing and getting your documentation in there, and it is there. So,
great. So then, one of the concerns of a number of clinicians has been whether this would require a lot of documentation changes. But it sounds like good documentation is good documentation, and that's true whether you're talking about ICD-9 or ICD-10.
Yes, sir. I agree. Absolutely.
Great. Well, Joe, let me pick on you again for a minute, since I've been doing that just a little bit here now. Talking about those clinician concerns, could you talk a little bit more about sort of the clinician concerns about the time that this is going to take for training? Is it going to be intrusive to the work of their office or to their practices?
Right. Well, clearly there is some time required for training, particularly on the coding side, because this is a fairly significant jump in that. But coders have done a fairly good job of getting trained on this, and there are probably more training materials and resources online through AHIMA, AEPC, other organizations to provide training that I'm a little less worried about the coders because they have tons of material available to them, and they've been taking advantage of that. The coders are really pretty aware, and I talk to a lot of coders about this. I think some of it is the office staff needs to be aware of kind of where their role is and the impacts. On the clinical side, I really think it's about understanding what are the concepts that are now required for ICD-10 that we should probably be documenting today, but if we don't have them as a normal part of our care, then that's going to be an issue going forward because we can't code to the right thing. Let me give you an example. So, for example, we know that musculoskeletal codes account for almost 60% of the ICD-10 codes, right? So there's a huge number of codes on the musculoskeletal side. So there's a great deal of concern that we've got this huge complexity, right? All of these new codes, thousands of new codes. But if you really look at those codes, there's a lot of recurring patterns. If you look at, for example, right versus left, that accounts for 30% of all the ICD-10 codes, right? Just the difference in right and left. Everything else is essentially the same. In addition, for every fracture we see, for example, you have to say whether it's an initial encounter, subsequent encounter, or sequelae, so you multiply that times each fracture, and then for every fracture you see whether it's healing, whether it's normal healing, delayed healing, non-union, or malunion. So you start doing that and you can see why there's so many codes, but the concepts are pretty basic. The other thing is a lot of those concepts can be moved up at the time of evaluation. The clinician may not need to say whether it's initial, subsequent encounter. That's captured as part of the initial intake. Which side it is, whether it's normal, if you're an OB, whether it's the first trimester, second trimester, or third trimester, and weeks of gestation, that can all be captured outside of necessarily the direct clinician's input at that point. It could be captured at the time the patient comes in and actually lessen some of that burden.
Right. Well, that's a good point as far as some of the other staff that need to be trained, because if you're explaining those types of things, then your intake staff, your medical assistants, those type of people can be looking for those sorts of things to help with the documentation.
Exactly. I think a lot of that burden can be lessened by having some of those folks just know some of the key things that you need to capture.
Right, right.
So it doesn't sound like that's really going to be a big issue. Requires work, but not an obstacle that can't be overcome easily. How about the question of software and the whole question of upgrades and other issues related to change in software? This is something else where I think we've been hearing a fair amount of concern. Could you all, as a panel, talk about that a little bit?
Yeah, you want to take
Sure. One of the things that I would recommend right away is checking with your software vendor that you're currently using and seeing where they are. Many of the vendors are already putting together webinars and those types of things that they're kind of doing a proactive approach, saying that this is where we are, and trying to keep their clients informed as to where they stand in the process. And I think it's a really good idea to attend those, to pay attention to those.
Yes.
And I know that some of them are pre-recorded, so I know if you're in a small office and you feel like you can't take the time during the middle of the day to do that, you know, you can probably find that online. And I recommend definitely making sure that you know where your vendors currently are, and that means your EHR and your practice management vendor, but also any clearinghouses that you may use, because they're also a big part of this. And so just knowing where they're at, and if they're not doing webinars and training already, then you need to find out why not. So I think that's a really important thing to be looking at.
I
right
agree.
now.
Yes, absolutely.
Working with clearinghouses is a great example of working with an external partner, and I would assume that there are a lot of other partners that even small offices have. Carla, could you make a couple of comments and then the rest of the group chime in?
You got to think about, for instance, I'm a nurse, we're ordering labs and things. Is that code, or is the other end going to accept that same code? You know, your hospitals where you send them, you know, for different procedures and testing, any of your labs and that kind of thing. We use outside laboratories. We have a reference lab we use. Are they going to be ICD-10 compliant, that kind of thing? And I think you need to look at that, your forms and all that kind of stuff. I mean.
And is that as simple as picking up the phone and calling them?
It definitely is. Yes.
Great.
Well, it can be, but then sometimes sometimes there's some, you know, you run into problems because they don't know where they stand, and so you know, but it doesn't hurt to pick up the phone and make that call and find out.
And I think one extension of the picking up the phone and calling, you don't just ask, will you be ready?
Right.
You also have to ask, what does ready mean?
Right.
Yeah, does ready mean that that's going to meet your needs?
Right. I know one of the things that we're doing in our local community, which is very helpful, is we're working directly with the hospital. And what we've found in previous transitions, for instance, when several of the practices went on to electronic health records and so on, we found that we were training in our office, and then the hospital was training in the hospital, and it was different. And so we've decided that through the ICD-10 transition, we're going to try to do some things that are more coordinated as an effort. And so the hospital is working with the offices directly to explain to them as far as what is going on with the internal forms at the hospital, what their needs are, and what each different specialty might be looking forward to. And so that is very helpful to us, and we're working as a group, and you know, each specialty one piece at a time through the process. And hopefully then the whole group will come together, and it'll help the local transition. It's not going to help the overall transition as far as clearinghouses and that kind of thing, but at least what we're doing internally and with our own hospital system, I think will be really helpful. And you know, I encourage other hospital systems across the country to look at doing something similar. Yeah. It's been a great program.
Well, with all of these interacting parts, it sounds like it may not be till towards the end of the time frame that all of the pieces finally come together. From a testing standpoint, since you have to test your own systems as well as the outside entities, does it make sense to start testing before all systems are up and running? Do you have to wait for training to be completed, wait for all of the software before you start testing? Or, Joe, I know you deal a lot with testing. Could you talk a little bit about this?
Yeah, I think when we talk about testing, there's, as you mentioned, there's a lot of different pieces to testing. There's the internal testing, external testing, but inside internal testing, there's component testing, there's business testing, there's all of those different aspects of testing. Clearly, there's a lot of things that you can do in parallel, and actually at this point in time, you should do in parallel. So we should, for example, want to test this part of the office system to see whether they're going to be able to handle this. We may want to test these vendors to say where, and again, using that kind of a model of being able to take scenarios, right, that you're common with today. So if you're an OB, for example, you may develop a scenario about a pregnant woman coming in, getting admitted to the hospital, having a C-section, whatever that scenario is, and then actually running it through your office to see if your systems, if your business, if all different parts are able to handle that in a way that you expect. The more technical aspect of testing comes after that. First, you got to make sure the business is working correctly, because that's going to define your business requirements. And until you have business requirements, you really can't tell what the system should do, because you're not quite sure what the system should do.
Right.
Okay. So it sounds like then that the scenario testing, you're looking both at a scenario as in a patient type scenario, but also as in processes. What happens if a claim code is rejected, or what happens if I need to select a code? Is that correct?
Exactly. So if I go into a hospital, for example, they want to understand, well, are we ready? Well, I say, well, let's do a fire drill. Let's actually create a patient case. Let's run it from the emergency room, through admissions, through radiology, through pathology, through the operating room, through discharge, all of those different places. And let's see how that scenario would pan out as we go through, and where we might have some gaps, much as you do with a fire drill to see where there are gaps in your practice.
Right.
Is there anything different about that, Gail or Carla, when you're dealing with these external partners as far as the testing goes, seeing if their systems are working as well as your own?
In my experience, I've found that some of the vendors out there have test environments that they will work with you, and so that you don't have to use your database that's your real database, I guess. And so you could do a similar test through that. And in many cases, it's not just your EHR vendor, but the clearinghouses as well. So some of them aren't quite ready for that yet, but some may be, and most will be.
Okay. So then, as Carla pointed out, if they're not ready, you can push them in that direction.
Yes. I was going to say, pick up that phone again.
Great. What about external payers? The people that are sending the checks to you, which is very important for a small practice. Are there specific questions that you should be asking these payers?
I think you should be asking them the same questions you're asking the clearinghouses and the vendors and so on. Yes, you should definitely be checking, and probably starting with your provider reps. And but don't just let the provider rep, as was mentioned earlier, don't let them say, yes, we're on the path, and I want to know how and where are you and what are you doing internally to test. And I think you need to ask those questions as well.
So the key questions then, it seems to me that there are a couple of key questions that you as a small business, a small practice, want to ask yourself. And again, Carla, could you maybe summarize that up for us a little bit, because you've been there?
Well, you need to know are you going to be able to submit claims? Will you be able to complete the medical record? Can your EHR capture the ICD-10 codes?
Great. And then just be on the lookout for surprises, I guess. Super. Last question for the panel then. No matter how much you prepare in a big project, there are always bottlenecks, setbacks, barriers, and those surprises. Could you talk a little bit about your experience as to the greatest challenges maybe that you've had in moving ahead with this conversion to ICD-10 in small practices? And then also, what have you done to overcome those barriers?
Well, I know when I talk to small practices, the biggest issue is primarily awareness. They just aren't aware, and they don't really believe that it's going to impact them, or it's not going to impact them. We don't get paid on these codes, or there's other things. So getting awareness of this and realization that it's going to impact them, and that there are things that they need to do, I think is really critically important. I mean, what are your experiences with that?
I agree, and I also hear people thinking that timeline is a long ways away, and it really is not a long ways away. So they think, it can wait, or it's going to get delayed. I hear that one a lot. I don't see that it's going to get delayed, and I don't think we should be waiting to do something.
Exactly.
So I think I agree with you. Procrastination is a big issue.
Yeah.
Our providers were the same way. They were concerned at first, but after we've played with it and did some testing and auditing and things, they're really kind of excited about it now, and they look for it to be a benefit in the long run, and a better coding system.
Right. And that's what I found. Folks who started to do something about it suddenly breathe a sigh of relief, because they've said, oh, this isn't nearly as bad as we thought it was, and they're actually moving forward, and they see it's really kind of that getting started that's the hardest part, and getting people aware and realizing that it's important and get over that fear factor.
Right.
Great. Well, that sounds really encouraging. What about barriers as they relate to external partners? Do you have any particular barriers, say, with clearinghouses, for example?
Well, I think most of the clearinghouses are really well down the line to being ready to send and submit ICD-10 code on your behalf. There is this assumption out there that clearinghouses are going to convert your code from 9 to 10 or 10 to 9, and that's really a very false assumption. None of the clearinghouses, as their clearinghouse function, are really allowed to do that because they can't diagnose. You have to submit the information to them that says, here's my code, and then they can put it in the proper transaction format, but they can't go in and alter the patient's condition. So you really can't count on a clearinghouse to solve this problem for you.
That's a great point.
Mm-hmm.
Great. So then it sounds like providers will continue the documentation that they've been doing all along. They will make the transition to coding, and then the clearinghouses will help them process the claims with the new codes on them.
Correct.
Wonderful. So no significant changes are made without some effort, but a good stepwise plan, sufficient practice, and thorough testing can ensure that your practice will be ready when the switch to ICD-10 goes into effect in the fall of 2014. Remember that the objectives of your practice are to prevent disruptions in patient care, disruptions in workflow and staff procedures, and disruptions to overall efficiency of practice. And if you use a stepwise approach and look at this as something that's doable, you can make that transition without disruptions. On behalf of the Centers for Medicare and Medicaid Services, I'd like to thank you all, Joe.
Thank you.
And Gail.
Thank you.
And Carla.
Thank you.
For participating in this educational activity designed to help small independent clinical practices move forward with the planning and implementation of ICD-10. We'd also like to thank you, the audience, for participating in this educational activity. To proceed to the online CME CE test, click on the Earn CME CE credit link. Please also take a moment to complete the program evaluation that follows. Thank you.